Hello, hello, and good afternoon, good evening, good morning from wherever you're tuning in from. It's great to have you on another webinar that NSWOC and the Walk Institute here are hosting. We're so thrilled to be partnering today with Lipedema Canada, and we have a phenomenal guest speaker with us today. We're going to be introducing Emma Cloney in just a second, but before we get there, I'm going to do a couple little housekeeping items. First things first, I'll ask everyone to click on that chat button in your Zoom toolbar and let us know where you're tuning in from today. We're going to be using the chat button to interact with any other attendees that you'd like to speak with over the course of the Zoom call today. But if you have a question, we will be having a Q&A portion as well. So click on the Q&A button, not the chat, but the Q&A button if you have a question that you would like to ask Emma today. And that'll make it easy for us to keep them organized and get to as many as we can. As you may have already seen on the flyers and in the Zoom link, we're going to be going for about an hour and a half today, so a little bit longer than our usual webinars. And purpose of that is to make sure we can go through as much of this fantastic content as we can. Another thing to note is that we will be recording today's webinar. So if you do have to head out early, or if you have a colleague who wants to watch this back later, or a family member for that matter, friend, anything like that, we will be making it available to watch after the fact too. And this is part one of a two-part series. We'll be discussing a second portion of the series tomorrow evening. And the same thing will go for that. We'll be recording tomorrow if you're not able to make it. You will be receiving a certificate of attendance as well after the fact. Just give us a day or two and we'll get those into your email inbox. But that'll be a great way if you have any questions we don't get to today, you can always respond back to that. And again, be a great way for you to access the recording after too. So without further ado, I'm really excited to be introducing NSWOC's president-elect, Bev Smith, who's tuning in from Alberta today. Bev's going to take us through a couple things at the very beginning, but we're really thankful to have Bev on today to help with some of the moderation, some of the questions, and to participate in today's webinar. So I'll pass it over to Bev.
Thank you, Troy. Thanks everyone for joining us tonight. I was just looking through the big list of where everyone's at. Looks like there's people from all over Canada and maybe even the US and across the world. It's amazing. So thank you for joining us. As Troy mentioned, I am Bev Smith. I am the president-elect for NSWOC Canada. Very proud to say that. I'm very proud to be an NSWOC, and we just had our conference in Montreal that was phenomenal. I am originally from Nova Scotia. I actually seen on the list that someone's from New Glasgow. That's my hometown. So hey, shout out to you. I just want to introduce Emma. Emma I'm so glad to introduce her. I kind of met her through social media and whatnot. I don't know her personally, but getting to know you. So Emma Cloney is a women's health nurse and president and co-founder of Lipedema Canada. With over a decade in women's health, she brings expertise to her work in lipedema, a chronic adipose tissue disorder disproportionately affecting women. Diagnosed in 2021, Emma advocates for improved care access. Her advocacy led her to becoming the first Canadian woman to receive multiple medically necessary lipedema reduction surgeries funded under her provincial health care that was performed in the US and in Germany. Emma co-founded Lipedema Canada in 2023, and Emma champions patients' empowerment and professional education, aiming to bridge knowledge gaps and improve care standards nationally. This topic is close to my heart as well. I've been diagnosed with lipedema, so I'm really excited that you guys are all here to learn from one of our experts. So Emma, please take it away.
Thank you so much, Bev. So just a clarification on my bio, I was the first woman to receive international surgery covered by the province. Wow. There have been other patients who were covered by their surgeons in their provinces, but I was the first to receive it nationally. So just a point of clarification for those that need it. Thank you so much for having me here. I am excited as a fellow nurse to be presenting with NSWOC. So the topic of our conversation today is the lipedema landscape. And we're going to go over a head-to-toe assessment and addressing Canada's awareness gap. So I look forward to everyone's questions. So as Bev mentioned, my name is Emma Cloney. I am a registered nurse working in women's health, specifically in obstetrics and neonatology. I am the co-founder, one of the co-founders, there's several of us, for Lipedema Canada, Lipedema Canada. I am an advocate and an educator. And most importantly, my journey with lipedema started as a patient. I was a nurse without any knowledge that lipedema even existed when I found myself on disability, disabled by it. And so it has been a wild ride And so I hope today that from our conversation, there will be lots of good information that gets passed through scholarly sources that will help everyone who is here, whether you're a patient or a clinician, better understand the disease so that maybe we can be the last group of people that didn't know anything about lipedema. I hail from Lipedema Canada, Lipedema Canada. We are a national not-for-profit charitable organization which advocates for lipedema in Canada. We were established in 2023 by a series of very committed individuals, all of whom are lipedema patients, and our mission is to open minds and change lives. So when it comes to disclosures, I have nothing financially to disclose. I would, however, like to make very clear that Lipedema Canada is not a medical provider. And as a registered nurse and a volunteer with Lipedema Canada, I do not provide a medical diagnosis, including for lipedema. Within my scope of practice under the College of Registered Nurses of Manitoba, I am authorized to provide evidence-based education on assessment and health promotion topics, such as the head-to-toe assessment for lipedema. The information presented in this webinar is intended for educational purposes and informational purposes. It is designed to support clinicians in their practice to be applied at their discretion within your specific scope of practice, as we know that there's a variety of types of people joining us today. And for anyone from the general public, this content is for information and interest and is not a substitution for professional medical assessment. And if you suspect that you have lipedema, please consult a qualified clinician. Let's get into it. So we're going to focus on covering a couple of things. We are going to describe the clinical characteristics and comorbidities of lipedema. We're going to perform a basic head-to-toe assessment. We're going to recognize the referral pathways and interdisciplinary roles and where are the roles of different practitioners. We're going to identify lipedema on impacts to quality of life. We're going to discuss challenges in accessing care, which of course we will cover in much more depth in part 2. And we're going to explore stigma and bias in lipedema care. All while working to improve and apply the knowledge that we have in order to have earlier recognition. So what is lipedema? And this is where I wish I had made a quiz and we could take a poll about what everybody thinks lipedema is. Because I must be honest that when I first learned about what lipedema was, I was flummoxed, flabbergasted that as a relatively recent graduate within the last 10 years that this wasn't taught in my school. And when I came to know that it really isn't well known in Canada at all, it was baffling. So what exactly is lipedema? Well, lipedema is a chronic condition characterized by the abnormal accumulation of fat in the lower body, particularly affecting the legs and sometimes the arms, while sparing the hands and feet. Now, this is not to say that lipedema tissue can't live in other places, but this is the specific criteria in order to say that is lipedema. Lipedema often results in a disproportionate body shape, and it can lead to significant physical discomfort and emotional distress. And lipedema is chronically misdiagnosed or mistaken for obesity and lymphedema, leading to undertreatment. So let's talk about the lipedema basics. In order to be considered a lipedema diagnosis, a lipedema patient, you would have to have the following things. Bilateral, meaning both sides of body. Symmetrical, meaning effectively equal. Disproportionate, unequal to the rest of you. Accumulation of fat on the legs or arms, sparing the hands and feet. It would be painful fat. It would be nodular or grainy texture for the fat. A patient would have difficulty losing weight in affected areas. There would be easy bruising, and there are impacts to mobility. And this is not a comprehensive list, but this is what we would consider the absolute minimum criteria. I want everybody to look at these pictures, which are kindly provided by the Lipedema Foundation. There is a misnomer, a myth that lipedema only exists in people living in larger bodies. And that simply is not true. Lipedema can exist in people who live in straight size bodies, relatively normative size bodies, ones who can still shop in average clothing stores. And lipedema can exist on a spectrum all the way to people like the one on the end, who is living in a much larger body and possibly has comorbid conditions. It is important to acknowledge that lipedema symptoms are not based on the size of the limb. Lipedema symptoms are valid. Pain is valid in a patient that is small-sized as well as in a patient that is larger-sized. So the other thing to point out about this image, of course, that I always like is look at all the different presentations of lipedema. Once you start to recognize the hallmarks of it, it becomes easier to spot it in a diverse group of patients. But just from looking at these photos alone, if each of these patients were in your office, would it be challenging for you to sort this out? So let's get through it. And I think by the end, if we were to come back, you'd feel much more confident about assessing lipedema. Okay, who gets lipedema? Lipedema affects women, those assigned female at birth. It rarely affects men. Less than 3% of the documented cases are in those assigned male at birth. So as a women's health nurse, I would adamantly state that lipedema is a women's health condition. Of course, I acknowledge women AFAB. Wow, 1 in 9. Well, lipedema is not rare at all. There's another myth that goes around that lipedema is a rare disease. Lipedema isn't rare. It's rarely diagnosed. An estimated 11% of the female assigned at female at birth population may have lipedema. Based on the Stats Canada, of how many people there are in Canada right now, this minute, that's over 2.2 million Canadians. 1 in 9. If you know 20 people, you know at least 2 people with lipedema. So this is a great reason why webinars like this are so timely and why, as a patient, I'm so passionate about advocating, because when this many people are affected, which is almost the same proportion as number of people who have breast cancer, it is striking to me that this is not well known and understood in Canada. So let's keep going. Okay, what causes lipedema? Well, I wish I could give you all the answers on that, but I can't. The exact cause of lipedema is not yet fully understood. This is due to lack of research funding, and even though lipedema has been in our literature since 1940, it has only started gaining a lot of traction in research and development in the last 5 to 10 years. So let's tell you what we do know, and we'll always have lots of questions about what we don't know. So we know that lipedema seems to be genetic. They have identified some genetic markers for lipedema, including some genes that are associated with lipedema, but they don't yet have, researchers don't yet have a clear picture on if any of those genes are causal. So what we do know is that lipedema runs in families, and that indicates a genetic predisposition. We also know that lipedema is suspected to be inherited via the X chromosome. So that means that it can come from either the maternal or paternal side. This is important for you to remember as we move through this. When we're doing our patient histories and physicals, doing patient histories that include both sides of the family is going to be very relevant. So we also know, well, what triggers lipedema? Hormones. We believe that it is a hormone triggered based disease. So specifically, the onset of lipedema seems to be directly correlated to hormonal changes that are often listed as puberty, pregnancy, menopause, sometimes the start of hormonal birth control, trauma, or stress, or even surgery. But most commonly, puberty, pregnancy, menopause. So again, going back to, this is an AFAB women's disease. When we talk about hormonal factors, estrogen's role in fat disposition is significant in the context of lipedema, according to the research. So we are waiting for a more definitive answer on specifically what part of estrogen is causing such an issue for us, and what does that mean for us as we go through the phases of life where our hormones change, including perimenopause and possible hormone replacement therapy. Now, while I can't speak to that, we do have a webinar on lipedema and menopause coming tomorrow at Lipedema Canada, and I'm going to let the doctor answer those questions. Okay, what's comorbid with lipedema? Well, for those of you who are not medical professionals, comorbid means conditions that live together. sometimes bedfellows. When it comes to comorbidities for lipedema, let's think connective tissue. So below is a list of connective tissues in your body. And you might notice that connective tissue supports and surrounds nearly every part of your body. And fat is a connective tissue. So when we start to look down this list, skin, fat, bones, cartilage, tendons, ligaments, blood, lymph, fascia, organ linings, joint capsules, and blood vessels. Well, that's basically all of you. So what conditions could be affected by your connective tissue? This is not even a comprehensive list. The list here of comorbid conditions in no particular order on my side is obesity. So note that lipedema is not obesity, but they can be comorbid. Hypermobile Ehlers-Danlos and hypermobile spectrum disorders. POTS, which is postural orthostatic tachycardia syndrome. Allergies and mast cell activation syndrome. ADHD and other forms of neurodivergence. Migraines, hypothyroidism, gut issues, depression, PCOS, sleep disorders, high blood pressure, arthritis, anxiety, depression. I could keep going. What I'm getting to is if you look at this entire list, you realize that every one of these things is deeply interconnected with connective tissue. And when we have patients who have multiple diagnoses or multiple entrance complaints, sometimes when they have so many things going on, it's really hard to sort out whether or not you send them to, do you send them to an OBGYN for their PCOS? And do you send them to a sleep disorder clinic for their sleep issues and to a psychologist for the anxiety? But outside of that very siloed approach, if we take a big step back and we realize that these things might all be interconnected, that's another clue that we're dealing with a connective tissue disorder, such as lipedema. Now, I mentioned hypermobile spectrum disorder and hypermobility. It is estimated that about half the population, the lipedema population, may be hypermobile. And this is correlated between a connective tissue disease and hypermobile Ehlers-Danlos, or often also referred to in other criteria as hypermobile spectrum disorder. So when you're assessing a patient to find out if they have lipedema, you should assess if they are also hypermobile, because this can have implications for their gait, for their joints, and for their overall stability when doing exercise activities or work activities. So hypermobility is often assessed through something called the Baton scale, but that's for another day. I think what I love about this image, also provided by the Lipedema Foundation, is that despite the size of anybody's body here, you can see how unbelievably flexible these individuals are. The ability to touch the floor without bending your knees, bend your hands all the way back, or provide the crinkle fingers that we have, are all signs of hypermobility. Not every lipedema patient will be hypermobile, but it is an important assessment. So there are, I won't get into the specifics, but there are considered to be subtypes within lipedema, and one of them is a hypermobile subtype. Okay, so there are a lot of psychological and social impacts. I showed you some photos of what lipedema looks like, and there is a really high incidence in our community, much higher than the average population, of depression and anxiety. And while it isn't fully understood if this is a chicken or an egg situation, like what I mean by that is that the research talks about, do we think that patients with lipedema are depressed and anxious because they have lipedema, and that causes emotional distress about their appearance and their mobility and other concerns? Or is it possible that these conditions pre-existed? And the research is still developing, but one of the points of research talks about having dysregulation long before the onset of symptoms. And so that leads us to believe that depression and anxiety may exist in our lipedema population long before they look like they have lipedema. There is also a statistical correlation between ADHD and lipedema. And we know that ADHD often creates a lot of anxiety, especially if nobody has diagnosed that person. And so that's something for consideration about what is the cause of the depression and anxiety. But because we don't have a clear answer, we can't answer that question right now. Tremendous issue, reduced mobility. So lipedema is an incredibly painful and disabling disease, and it can be disabling at any stage. You don't need to have advanced to the point where you have very large limbs to be experiencing massive amount of dysfunction in your daily living. The reduced mobility can be coupled with issues like arthritis, with joint pain. And when the limbs get very, very large, it can be an actual just physical issue about managing to move through the world in a larger body. But it's important to note that for myself, because I can speak as a lipedema patient, even as young as 12 years old, in an 80-pound body that danced and swam and had no idea I had lipedema, I would experience extreme pain in my feet and my legs on any kind of long-standing effort or long walk. And that didn't make a lot of sense until many years later when I learned that that is a very common issue for those of us with lipedema. We can experience that pain again long before symptoms show up. Social isolation is also a really big issue. Having a body that doesn't follow the rules, that doesn't look like you want it to, or that you feel that you've earned for it to look like, or where people stare or make comments, can lead some of us to just not want to go out, to not want to participate in things we once loved. And some of our activities that are the best for us are things like participating in swimming or walking activities if you're able to. And I can say honestly that having the wondering eyes look you up and down questioningly, sometimes kindly and sometimes not, can be very isolating. There's also, because lipedema is not well known or understood, if you don't really know what's wrong with your body and you don't know that anyone else lives like this, that itself can also be a source of isolation. And financial barriers. Financial barriers are a huge issue for the lipedema community. So what I mean by that is that in order to treat lipedema, you need to be able to afford things like compression garments or physiotherapy, sometimes special ways of eating where you might need more expensive groceries. You may have higher sick time at work, and you may also need surgery for lipedema. And none of those things, none of the treatments, compression, physiotherapy, or surgery, are covered by either private insurance or public insurance, like the provincial healthcare system at this time. So it can be incredibly expensive. The barriers of managing that care in any province are really challenging. Okay, moving on. So how do we diagnose lipedema? Lipedema is diagnosed based on clinical evaluation. So through a thorough medical history and physical exam done by a healthcare professional who is familiar with lipedema, that part is essential. Lipedema can look like a lot of other things. And so the part about being familiar with lipedema is what can help prevent sort of those wrong diagnoses or inaccurate diagnoses and provide best patient care wherever possible. And the question is there any testing for lipedema? Well, technically and presently, there is no objective test for lipedema. Now, that doesn't mean that a lipedema diagnosis isn't valid, but it does mean that it is more challenging, especially for clinicians who want to get it right. So you should know that there is no blood test, urine test, or imaging test at this particular time, although there is research for all of them. And we are really hoping that at some point they will come out with an easy test that can definitively say, yes, your suspicions are correct, that patient has lipedema. Okay, so now we're going to get into the diagnostic criteria. Forgive me while I wet my whistle. Okay, so I'm doing this in the nursing model. I want to acknowledge all of the nurses who may have joined us here this evening. Thank you so much for coming to a talk where nurses talk to other clinicians and to the general public. So I've structured my presentation in the nursing model, and I hope that that will make a lot of sense to most of you. So first, we're going to talk about the history, patient history. This is the subjective things. For those of you listening at home that aren't nurses, that means the things we can ask, but we couldn't assess ourselves. We need to talk about a patient history. We need to ask the patient, when did they have the onset of symptoms? When did your body change? When did it go from whatever you looked like as a child to whatever big change happened? Was it that you started to thicken in the thighs and then you just kept gaining weight from the waist down or in the arms? Did you have no symptoms until you got pregnant with your first child and suddenly everything changed? Or maybe you were one of the people who got all the way through puberty and pregnancy and then found themselves perimenopausal with a body that was already very challenging because there's not a lot of great information from just general sources on perimenopause. And then all of a sudden your body changed and you went, I don't know what's going on. I don't know why I have so much pain and why my limbs are changing. And I didn't change my diet. I didn't do anything different. We have to do a good patient history. We also need to ask, oh, I broke the thing. Hang on. There we go. We need to talk about our family histories too. So we know that lipedema is supposed to be genetic. It is assumed to be genetic. And so if you look down your family tree, you're going to want to say, do we have people in our family pictures, in our history that we know of, who had similar body types? Maybe you have somebody who had a really big hips and bum and always needed to like sort of lean on something or sit down. Or in my family case, we were all nurses going back a lot of generations. And so I found out that my grandmother, also a nurse, she used to wear compression pantyhose, like not medical grade compression pantyhose, but she was always wearing pantyhose. And we suspect that this might have sort of been a coping mechanism that she found through not really knowing what was wrong with her body, but ways to cope. It's also important to note that while I have lipedema, my daughter also has lipedema, and you may have people in your family where it skips a generation. It might be that none of your sisters or your cousins or anybody has, but we look back to Aunt Sue and she did. So again, do a really good assessment of all family members who were assigned female at birth. Patients might report to you that their symptoms are worse in the summer. Heat exasperates it, or with prolonged standing. Standing with dependent legs or sitting even with dependent legs for long periods of time can really increase that feeling of heaviness in the legs and cause a lot of discomfort. And so for myself as a nurse, the prolonged standing was a hint that something was really wrong. I was struggling more and more with that. So again, add this to the questions you're going to ask. Here's a really important one. We're going to touch on this in much more detail, but patients will report difficulty losing weight in affected areas. Okay. For our physical assessment, so we're going to go over the history and then the physical, and then we're going to get right into the pictures and really start diving in. So physical things, the objective, things you can touch, things you can assess. So you're going to look and you're going to see that the patient with lipedema will have bilateral, both sides, symmetrical, equal, fatty enlargement of the limbs, whether it be the legs and or the arms, with no involvement or minimal involvement to the hands and feet. There will be pain and tenderness on pressure or palpation to the affected tissue. They will have easy bruising, and they will have persistent limb enlargement after weight loss, as lipedema fat is resistant to diet and exercise measures and often to bariatric surgery. Now, I want to make sure that you saw the part where I underlined lipedema fat. Regular adipose tissue, regular healthy adipose fat, obesity fat, can be metabolically active and therefore can have an impact from diet and exercise measures. But when your patient says to you, I have difficulty losing weight, and they're referring to that they may have lost weight in their core, maybe they lost weight in their face, and maybe they even lost some weight in their legs, but overall, the limbs do not change proportionately to the amount of weight lost elsewhere. And this can create what really looks like a two-body syndrome. I'm going to show you some pictures of that in a minute. The texture of lipedema fat is unusual. It is nodular or grainy. There will be what's called a negative Stemmer's sign. So for those of you who treat lymphedema, and we will again cover this in slides coming up, when we go to assess if lymphedema is present, you will find that in lipedema patients, the Stemmer sign is negative. And also, of important note, lab results for these patients can be completely normative. What do I mean by that? Well, if you have a person in front of you who lives in a much larger body and your immediate supposition is that there must be something metabolically wrong with them, thinking maybe they have diabetes, maybe PCOS, something is going on, some kind of insulin resistance, you will likely find upon lab results that all of their labs are in the normal range. Now, this isn't always the case. As we did see in our comorbid conditions, there can be things like hypothyroidism and other such issues. But as a general rule, it is not uncommon to see folks living with lipedema, potentially in larger bodies, with completely normal lab tests, which only baffles the clinicians more. All right, so let's talk about lipedema fat disposition. So I have donated my body to science. So there you go. This is at the time of my diagnosis and before any of my lipedema reduction surgeries. This was what I looked like as a 37-year-old individual, otherwise totally healthy, living with lipedema. So I want to note that you will see disproportionate, okay, bilateral symmetrical fat of the limbs, enlargement of the limbs. So please take note of the size of the waist, okay? Much, much, much smaller, disproportionately smaller than what you would expect from the size of the arms, the size of the hips and buttocks. It's also important to look down to the feet, and you're going to notice a couple of interesting things. First off, for those of you who are looking for the gait and standing, we're going to see that there's what's called a valgus knee. So basically, the ankles sort of flop in, the knees sort of flop in, and this is all part of having hypermobility and connective tissue issues. So when you're looking, you're going to see no involvement on the hands, no fatty involvement on the feet. But I want you to note that there is a tiny cuff. Look down to, let's start with the wrist. You will see that the fat tissue, while it does cuff fairly significantly at the elbow, it also cuffs at the wrist. While it is more subtle, it is still absolutely present. You'll also notice when we look at the picture from the back, and I'll just bring my cursor in here just so that you're not having to imagine, this fatty lobule on the arm overhangs the normal anatomy of the elbow. And in all cases, lipedema here is changing the normal anatomy. And we're going to talk about what that means as we go through more pictures. Ignore my screen, doing my screen things. All right, next. And this is a really important development that came out recently. In 2024, our friends in Germany put out their SK2 German guideline for lipedema, so their standard of care effectively. And in there, they described that pain is a required symptom for diagnosis. They cited it as pressure pain, tenderness, spontaneous pain, and the sensation of heaviness shall be considered as symptoms, all in relation to lipedema. They must all be present. Okay, now the next series of slides that I'm going to show you, these are fascinating. And at the end, the video from Dr. Sandro Michelini is going to be available in a QR code. I'm going to talk about what he taught us, very high level. And then I really encourage you to go and watch that video because he shows you in real time how he physically handles the patient and assesses these things. So please keep that in mind. All right, so pain and tenderness and on pressure on the affected tissue. So Dr. Michelini states that pain on palpation, so pain on touch, in the subcondylar, supracondylar, and supramalleolar locations only exist in a lipedema patient. So that is the only disease where when you touch a patient in those areas, you will elicit a painful response. And this is why we cannot make a lipedema diagnosis. A clinician cannot make a lipedema diagnosis simply from images. You have to get hands-on with your patient. So Dr. Michelini talks about these areas that I have circled and the order in which to palpate and assess them. He talks about, let's go first to the supracondylar, which we sometimes in colloquial layperson terms call the medial shin fat pad. So that's these protrusions here. He states that that will be the first area you're going to want to assess when you go to provide your pinch test. I'm going to show you what that looks like in a minute. Then you'll move up to what we sometimes call the medial knee fat pad, which was also very evident in the other photos from before. And then last, an assessment of the pain through a pinch test is going to be done at the medial ankle or supra above the malleolar bone. So this is an image directly from his video, and he states that they're to be palpated in this order. And the reasons for this was The first was that the, oh, I think I labeled these backwards. I'm sorry. Hang on. My apologies. Everyone, please make a note. The medial knee shin pad, I did label this backwards and I apologize. Subcondylar should be done first, and that is because it is the most painful area. So note the slide in front of you is incorrect. Subcondylar will elicit the strongest pain response on deep palpation done through a deep, solid pinch. Second to that would be the supracondylar. That's the most moderately painful. So it will still be quite painful, but it will not be as painful as the medial knee shin pad or subcondylar area. And then least painful, but still not painful, is going to be just above the ankle. So he shows us how we're supposed to pinch. And the reason for this is that we want to use enough firm pressure to get deep into the tissue. What he has aligned for us here in the pictures, I'll go back for a second. What he explains in the video, and I'm not going to recreate for you, I really do want you to go and watch that video from the doctor. But he identifies that the red line that he has drawn on this image is the medial saphenous vein, and that it is suspected that the vein and the nerve that run right next to it might be in a compartment that is being affected by the lipedema tissue, making it especially sensitive to pain on palpation. So he says that these points along the body, which I can tell you as preparing the slides with other nurses from Lipedema Canada, we both whinged when we looked at these areas being touched because we just know how much it hurts. So you'll see this red line and it'll come up again as we move forward. So back to the pinch. He says that it's important that you pinch into the deep subcutaneous tissue. So the deep fatty tissue, there's two layers of fatty tissue between skin being the top and then obviously muscle being below. In that sandwich layer, the thin layer towards the top is superficial, but lipedema fat lives in the tissue layer that's just below that, the deep subcutaneous. So when it comes to this area, you do want to get a good firm grasp, C, as he shows in the video, and you want to do a deep pinch into that tissue so that you can assess not only the texture of the nodules, but also elicit a pain response. Curiously, a similar pain response, but with a different technique, is found in the arms. So he talks about palpating the post-brachial compartment of the arm. So you'll see that in the image of my body over there. And here we use a different technique in order to palpate. Here, you're not going to use a deep pinch, but actually the elicit pain response is going to come from the superficial tissue. So you're going to want to use a lighter pinch, but nearer to the skin and less deep into the fat. He stipulates that the superficial will be very painful, but deep pressure, if you were to take a deep grab, it would be not painful. Now, he says not painful, and I, as a person with lived experience, might tell you that I think there still is some pain, but maybe I would say that it was less painful to have a big grab done versus something small. There was definitely a difference in sensation, but I can't answer this from a science perspective because in this context, I am not a doctor. This is a big one. Folks, when you have lipedema, and if you have lipedema in your arms, it is painful to have your blood pressure taken, probably for the exact reason we just talked about on the other screen. Having your blood pressure monitored is incredibly painful. And when our pain response is triggered, the results that we get from a blood pressure reading are not accurate. You can have an increased blood pressure reading from pain. And so it's also really challenging as a standard blood pressure cuff would rarely, if ever, have fitted my arm previously. And lots of lipedema patients are going to have arms of all different sizes, but typically that columnar shape. So here are some options when you are assessing. If you're the kind of clinician that does deal with blood pressure, some doctors have recommended doing a manual blood pressure instead of letting an automatic or Dynamap machine take over. You can use only as much air as you need in order to get your reading and then back off. As well, if you have a wrist cuff or you need to use a smaller cuff on the wrist, you can often get a much more accurate blood pressure reading from a patient on the wrist and elicit less pain, which is more likely to give you a better result. But all in all, reading blood pressure on a lipedema patient will cause pain. So if you have a patient that expresses pain, this is an excellent time to apply empathy.
Emma, I hate to interrupt for a second, but do you mind just going back 2 slides just for the QR code for another couple seconds? We had a couple people who were looking for that just one more time.
You got it. No problem.
Awesome. And maybe there you go. And maybe what we can do too is maybe when we send over the certificate of attendance, maybe I'll grab that QR code from you. We'll put in the email to make it easy for people in case someone does miss it later. But
Yeah.
I see some comments in the Q&A box about that too. So we'll just give everybody a few seconds. It's right at the bottom there if you can't see it right away. So we'll just give you a few more seconds before we move on. And I'm sure if we need to come back, maybe at the very end, we can always, oh, there you go. Even better. Thank you.
There you go.
Awesome. And just reiterating some messages from the chat while we're taking a quick little break here. Just some people are talking about, yes, oh my goodness, blood pressure. Absolutely. I'm assuming for this person, it's very painful for them as well. Yeah, a lot of thank you so much is for everybody as well. So hopefully we can maybe move on now, but thank you for going back to the QR code.
Awesome. Yeah, and I'm glad that worked. Thank you for checking in. Okay. Now we're on to easy bruising. Okay, so when I was in kindergarten, my teacher went around the room and played a very interesting game. I was 6 years old and a thin body showing absolutely no signs of lipedema. But as we all sat as children with our legs sticking into the center of the circle, she went from one child to the next and she said, Susie's legs are, white, and Andrew's legs are brown, and Emma's legs are blue and purple. And that's because the hypermobile connective tissue part of lipedema, the connective tissue issues, lead to vascular fragility. So you will have easy bruising. I call these bruises of unknown origin. They can look awful and they can be from very little contact. Sometimes it's as simple as pain and bruising from your child, a little kid, standing up in your lap when you're holding them, or a pet walking across you. That'll elicit a big pain response. And then later you'll look down and you have bruises where they walked on you. And if you will happen to be someone with lipedema, you might also find that your gait is affected. Sometimes you're clumsy and you so much as bump into a doorway. And then you have these huge bruises of unknown origin. And the one that I've highlighted in these pictures, I think I actually grazed my bike pedal. And I had a bruise, the one that I've highlighted, that lasted for 4 weeks and looked like I had kicked a fence or something. It was terrible. I didn't even know it was there until this photo was taken. So, okay, now this is a big topic. This is important. We talk about lipedema fat being resistant. Now, the pictures in front of you, all right, are relevant to the patient history that we took, where you asked your patient, tell me about times where you have tried to lose weight. And patients might report to you, well, I did XYZ and I lost weight, in my core and I lost some weight in my legs, but I got to the point where I just plateaued. I couldn't lose any more. My legs didn't change. A lot of patients actually find out they have lipedema post-bariatric surgery. And that is what this image is. This is a lipedema patient who had bariatric surgery and lost a significant amount of weight. And what you can very clearly see is that they did not lose their lipedema fat. And that's because we've been told and we've seen that lipedema fat is incredibly resistant to conventional weight loss methods. So why is this important? We're going to touch into stigma and bias as we go, just weaving it through the presentation. A lot of the advice we get when we go to our clinicians is not always based in evidence. And a lot of weight loss advice is not really evidence-based at all. The use of BMI, not evidence-based. The use of BMI in lipedema patients, absolutely not appropriate. We should be using waist to hip ratio for lipedema patients. But a lot of the advice that we get is, have you tried eating less and moving more? That is problematic and toxic advice, as lipedema patients often struggle with undereating, disordered eating of all types, but very specifically restrictive eating. Because if your belief, and you've been told your whole life, is that you should just try harder and then your body will somehow relent and listen to you, a lot of times you can feel like this is a moral failing on your part, that your body doesn't look the way that you think it should. And that goes back to talking about some of the psychological impacts of lipedema, is this onus of blame. When we talk about a lipedema diagnosis, despite there being no objective tests, the thing that you can offer to your lipedema patients is to validate their lived experience. It is so incredibly validating to know that there is an answer to why your body doesn't make sense. And I really want to focus in on whatever lifestyle advice is being given out for someone you suspect has lipedema should be based on managing symptoms and not on the cursory goal of weight loss, because that is not a realistic goal. Now I want you to look over to this very slight individual on the far end of our screen. This is a fairly famous image of a lipedema patient who is suffering from malnourishment and anorexia. But if you look at the top half of their body, they very clearly look malnourished. And then you look at the lower half of the body, and you would never match the two of these bodies together. If you had these on separate images and you had to guess whose top and bottom go together, you wouldn't assess this. But this is furthering the understanding that lipedema fat is not going to be reduced by diet and exercise. That's not to say that there isn't a role for nutritional intervention in lipedema, and it's going to be based on reducing inflammation and dealing with symptom management. Okay, for those of you who didn't want to see gross pictures, I gave you exactly 0 trigger warning, and I'm sorry. Lipedema fat has an unusual texture. It has an unusual texture when you palpate through the skin. So it can feel nodular or grainy, sometimes referred to as feels a little bit like sand. And then in other parts of the body, or even on the same patient, it can feel like pearls or barley, sometimes called rice or beans, or even walnuts beneath the skin. These nodules in the lipedema fat become part of a fibrotic matrix, which you can actually see in the image called lipedema fat. This is loose connective tissue where the fat cells grow and grow. They're hypertrophic, they're huge, and they become deeply enmeshed in this fibrotic net. That's actually what creates the look of cellulite. Go back here. It looks like cellulite, but it isn't. It's deep bands of connective tissue, and you'll see that on my pictures as well. So you can't, there are no creams to get rid of that. All right. Now we talked about lymphedema. We're going to talk about it more, but back to how do we assess for a negative stemmer sign. So when we talked about there being no involvement to the feet or hands, when you go to assess your lipedema patient, you're doing your full head to toe. You have your hands on the body. You're going to go down to the ankles, and then you're going to go to the toes. When we are assessing if there is the presence of lymphedema, the Stemmer's test shown in front of you, it basically is a little bow tie pinch on the second toe. And from there, if you're able to pinch the tissue together neatly and tidily, then that would be considered a negative. And if there is the presence of edema, fluid, even a mild amount, you will have difficulty doing that, and it will create more of a bow tie looking effect. That would be a positive stemmer sign. To our OTs, PTs, nurses, and people who do that every day in the comments, if I didn't get that fully right, please make sure you write to me and say so. But my understanding is that is a good way to describe the Stemmer's test. It is important to note in a lipedema patient that yes, in lipedema exclusive without any comorbidities, it will be negative, often negative. However, there is a co-occurrence of lymphedema, separate disease, and lipedema, separate disease, sometimes referred to as stage 4 or sometimes referred to as lipolymphedema. And in that instance, your patient would have both and might actually have a positive stemmer sign. So lipedema likes to keep it complicated, to keep you guessing. Okay. So we're going to look at these images and we're going to do a head to toe. And this is going to be done more verbally because otherwise this would have been like 200 slides. So I really want to point out, let's look at our patient in the office. Okay, we're going to start over here on the living human being, other than my drawing. We're going to go over here. So first, I want you to assess how the patient stands in the room. Okay. Get them to stand feet shoulder width apart, do a couple of steps forward and a steps backward just to get them to stand into a comfortable anatomical position. And we're going to look right from the feet. First thing we're assessing is there any swelling on the tops of the feet that we can visually see? In this case, no. Then you want to just have a look at the overall disposition of the person standing. Do they appear to be in alignment? Things we're going to notice. We have pronated feet, pronated ankles. This is commonly seen in lipedema patients of all sizes. So quite curious that it's not only and specifically held for people living in larger bodies, which at this time I definitely was one of those people. But this has to do with joint laxity, hypermobility, this inturning of the ankles, which again can cause issues with gait and pain at the feet. So then you're going to look to the outsides of the ankles. So here you're going to notice that there are bumps. And those bumps are sometimes called lateral malleoli fat pads. What are they exactly? They're usually non-painful, but they're lipomas. They can sometimes grow very large and make it very difficult to get shoes on. They are benign fatty tumors that can exist beneath the skin, and sometimes there can be 4 of them in total between the 2 legs, one sort of more to the anterior portion or the front, and then one more to the posterior portion of the back of that ankle. Again, making it really challenging to find shoes that lace up. Then you're going to look for the cuff. Now, a cuff sign is going to be very dependent on what type of lipedema a patient has. We are going to get to type in a minute, but in the meantime, I want you to know that type refers to where on the body does the fat sort of terminate? Where does it stop? What starts to look more anatomically normal and what's not? So in my case, looking at me here, I'm a type 3, which means I'm affected from the umbilicus all the way down to the ankles and from the shoulders to the wrist. So back to cuff sign. A cuff will not always be present because sometimes you will have a patient who's, let's say, a type 1 or a type 2, where the tissue doesn't go below the knee in type 2 or doesn't come below the hip in type 1. In that instance, you wouldn't have a cuff. So what I'm saying is a cuff sign doesn't always need to be present, but you should assess for it. Cuffs will sometimes be really profound. In this other drawn image, you'll notice that our model has a fairly profound cuff. You're going to notice similarities in every lipedema body. This is a different patient than this. Next, I want you to notice this inverted Y. This shape, when we're standing feet shoulder width apart, that sort of shows you that the joints are not in alignment, shows a valgus knee, which means that the knees knock inward, and that you'll have the same sort of gait issue where everything sort of just folds inward. The next important sign is that you're going to see those medial shin fat pads. These are so incredibly painful, and you will see them on pretty much lipedema patients of all sizes. And it will be painful whether it's really visually obvious or not. They can grow pretty out of control and get very large and really start to change the normal anatomy. So we're going to be looking for those medial shin fat pads. Next, and I always find this one very interesting, no matter what stage a lipedema patient is at, whether they're at stage 0 and they don't even know they have lipedema yet, or they're all the way up to a stage 3 and or stage 4 with lipolymphedema, there will be no visible kneecaps. It's like we don't own knees. Why specifically? They just kind of look like these little sad smiles. And you'll see this even on bodies that are relatively normative sized. It's just this like missing looking knee. When we have larger limbs, especially on the upper thigh, the fat will start to basically overhang the limb. And this creates the C curve, which only makes that lack of knee more obvious. So had I had a side profile of this myself at this time, you would very obviously see a very large C curve, not unlike what we see in the model here. Next, look at the texture of the skin. Look at the texture of the affected areas. You can practically pick out what parts of the body have lipedema and what parts of the body do not. This thick, fibrotic, cellulite-looking appearance is copious amounts of lipedema tissue. At the time of diagnosis, I was stage 3. And the stage in this case refers to has now significantly changed the normal anatomy. Again, you don't have to memorize that. We're going to cover it in another slide. So this is all very, very painful. You're going to look up the body, and then we're going to look for things like saddlebags and this interesting disproportion where the hips and bum seem so much larger and disproportionate to the waist. This happens in almost every type of lipedema, including those living in smaller bodies. There will be a significant disproportion in the way that the fat accumulates on the body. Up to the arms, you will see that there is some nodular fat in the abdomen, and this was quite painful, actually, but not the same amount of painful as here, here, or here, or here. Now, in the arms, this was a huge challenge. The arms are very heavy. Patients will complain that their limbs feel heavy, like they're full of concrete. So when you look to the arms, obviously you can see that this is not a normal look. You are looking for cuffing, again, elbow, wrist, sparing of the hands, and again, looking at the overall texture. So things that we want to drive home here, we're looking for a disproportionate upper and lower body. We are looking for painful nodular fat, and maybe yes, maybe no to a cuff. Okay, so this is a good overview. We're going to move this slide forward and look at some more people and some more scenarios. So this is a drawing of a patient at an earlier stage where the majority of their body is still anatomically normal. But we can note that there is a significant amount of fat deposit on the thigh, giving them that C curve on the thigh. It will be painful. They have no kneecaps. There is a cuff present, even though this person's limb actually looks relatively normative. Look, you do actually have a very small puff cuff. The lateral malleoli fat pad ankle lipoma, that's what this is. So I had brought a picture because, I don't know, nurses like to talk about gross stuff, I guess. But I wanted to make sure you guys had a picture of what that looks like. And when you're palpating it, it's interesting because it almost feels like a mobile golf ball underneath the skin when these lipomas on the ankles get going. Again, they can interrupt the ability to wear shoes, but wanted you to know that they can exist. They don't always, but they can. Okay, now the topic of stages of lipedema is one that's actually in development right now. So what I'm showing you in front and what we're going to first discuss is what is currently known as the stages of lipedema according to the US standard of care. So there are some standards of care in the world, and they have sort of helped us identify how do we classify a lipedema patient based on the stage or advancement of the disease. So in this instance, stage refers to the advancement or the progression, but I want to highlight again that pain and dysfunction can be present at every single stage, and is not that someone living in a larger body in our stage 3 body will be in more pain than somebody in this body. That just is not the case. It will be subjective, as pain always is, and each are valid and worthy of treatment. And so it's not about sort of waiting until the disease gets so bad that it looks as bad as it feels. Patients who are experiencing pain and dysfunction should be treated and offered good options for treatment. And we'll talk about the treatments shortly. So let's talk about stage. So the way the US standard of care breaks it down for us is based on what's called morphology. How does it look? So they say that a stage 1, which is the person in the white, okay, the skin will have a smooth texture with sort of a pebble-like feel beneath the skin. The underlying loose connective tissue will have that sort of little bit of cellulite appearance, but it'll be pretty mild. So again, when I use the words relatively normative, I'm talking about that at 100 miles an hour at the pool, would you clock this person as having lipedema? Probably not. In a stage 2 patient, there is more lipedema tissue. It has simply expanded. Now the skin is starting to dimple and you're seeing a much more obvious cellulite texture in the places where lipedema is affecting them. And this is, of course, suggested based on that fibrotic net that's down there. The more lipedema tissue that gets in there, the harder that net gets pushed against the skin or the subcutaneous tissue, causing those fibrotic bands to kind of pull down. And it creates this mattressing effect where the tissue goes in. So it looks like cellulite, but it isn't. The nodules now in stage 2 are going to be much more palpable. And even just from looking at these photos, you can see almost with your eyes that it's going to feel different than the person in the white in the stage 1. We're starting to see some changes to the normal anatomy, okay? But overall, with the exception of the cuff, this person is still relatively anatomically normative, but you can very clearly tell that there's something different. When we get to a stage 3, we're talking about significantly advanced and increased lipedema tissue. It is much more fibrotic in nature. When you palpate it, it's going to have firmer feel. It's just going to feel thick and heavy and dense. And if you are the kind of clinician that does things like massage or tries to do fascial work, you may have a near to impossible time palpating underlying structures because thick, fibrotic, advanced lipedema tissue you can't penetrate through it. Also, the attempt to do that will elicit an immense pain response and from your patient. And if they are somehow brave enough to endure that, they will return back to you the next day covered in bruises of unknown origin. We will blame you. So back to this. The stage 3, you're going to see changes to the normal anatomy. So at the stage 3, the knee is now being overhung with the fat. We are going to see a cuff or, it's hard to say exactly, but the picture of my body from behind, if we go back there in a moment, you could see that below the buttocks, there was actually a new sort of fat pads that had grown and had changed what the thigh looked like. And then the medial knee had these fat pads, and then the calves and the front, everything just starts to change. And it doesn't look like a normal leg anymore. So I mentioned that this is based on the US standard of care. But there was very interesting research. Like I mentioned, the German guideline came out in 2024. And in there, they provided an excellent suggestion for the change of staging to include the fact that the staging doesn't seem to encompass disease pain, its symptoms. What they have discovered from doing research on thousands of patients is that there are some people who live in this body who report very little pain, and some people who live in this body who are saying, I need to be on disability, I can't stand or walk. So the German SK2 guideline has suggested that they change the classification from staging based only on disease severity and morphology, but rather to the presence of pain and the impacts to quality of life and mobility. So what that means is that this patient in the white, if they say, I have so much pain that I can't work and I am needing disability, this person could theoretically be classified as a late stage or a stage 3. Again, this hasn't been formalized into any protocol yet, and it's a very curious piece of literature. So we're looking forward to all of the world leaders getting together and coming to more of a consensus on how we're going to stage lipedema. It's also important to note that depending on where you live in the world, lipedema staging can vary wildly. Because it's a subjective diagnosis done clinically, the UK only does stages 1 through 3. The US does stages 1 through 4. Depending on where you are in Europe, they might use 1 through 3 or 1 through 4. Lipedema is also called different things in different countries. It just gets complicated. So what we need is for everyone to come together and agree on some standard things. But for now, I want you to keep in mind, yes, you can stage somebody based on the anatomy, but please also consider what is their degree of disability. Types. So I've mentioned different types of lipedema. This is an illustration from Lipedema Canada. And everywhere you see in the blue is where they would be affected by their lipedema tissue. So in our type 1 and type 2, in type 1, affected from basically the belly button and into the hips. So those big saddlebags that you saw, but if that were to stop suddenly, the person would probably be a type 1, affected in the buttocks and in the hips, but really not necessarily anywhere else. They wouldn't have an ankle cuff. They may not have a wrist cuff, which is why, going back to cuffing, not always present, but should be assessed. Same with type 2. So from the belly button to the knees. Okay, so you're still going to assess for pain in all of these patients, and it is still probable that they will have pain in these areas. But you want to also just be mindful that the assessment for each of these patients is going to not always be as neat and tidy as you want it to, and should be thorough. And the attempt to stage them is sometimes way more complicated than you want it to be, but I digress. Moving on. Type 3, as I mentioned, my body type pictured in the images is a type 3, so affected from the belly button down to the ankles, sparing the feet. Everybody is sparing the hands and feet. Type 4 refers to arms. Arm involvement is estimated to impact up to 80% of lipedema patients. Originally, those numbers were much, much lower than that. But the more lipedema patients that are being interacted with, the more common the researchers are finding that lipedema in the arms is happening. It's important to note that type 4 rarely occurs in isolation. It almost always occurs mixed in with these other types. So you'll have someone who is most commonly, two most common are a type 2/4, so affected in the arms and then from the belly button to the knees, or a type 3/4 from the waist to the ankles and then shoulders to the wrists. So again, lipedema is not going to play nice and not going to make it super easy. Staging is less important than disease and symptom management. This is more for interest. Last, type 5 is a really unusual type, seen less often, but this would be a lipedema patient who has lipedema only from the knee to the ankle. And so they'll have relatively normative rest of their body, and the calves on this individual will be so disproportionate. It's actually a quite striking image to see. Okay, so you've gotten to the point where you've assessed the history, you've assessed the physical, you've touched, they have pain. Okay, now there has to be a differential diagnosis. So we have to be able to identify, and you're probably already asking this question in the comments, hey, Emma, how do we know the difference between obesity fat and lipedema fat? How do I know if a patient has lipedema or lymphedema or both? And I'll tell you honestly that this is a challenging issue for clinicians. It's a challenging issue for expert clinicians. But there are some things that give us some clues. So we're going to go through those. But we want to make sure we're doing a differential diagnosis for 3 different things. And one of them, before I move on, is non-symptomatic lipedema symptoms. So it looks like lipedema is what I'm saying. Like the fat disposition will be there, but there's no pain, not even on the deep pinch. That might be a condition called lipodystrophy. There's some interesting research about whether or not lipodystrophy is sort of stage 0 of lipedema before pain comes, but the research isn't clear. But for now, there can be a condition where it looks like lipedema, but isn't. So that's one part of the differential. So now we're going to go ahead and differentiate between lymphedema and lipedema. Okay. So in lymphedema, what are the basic differences? The basic difference here is that lymphedema refers to a blockage of lymphatic vessels, and lipedema is an abnormal accumulation of painful fat tissue. So while yes, they can look similar, they are very different. Things that are important to note: lymphedema can affect people of all genders, and lipedema almost exclusively affects those assigned female at birth. Now, I would love to ask a question in the chat, but I will do one of those hypothetical questions. Do you think that, given that we know lots about lymphedema, do you think that it's more common than lipedema? You might think so. You might think so. I thought so. I was like, wow, they have so much information. There's even coverage for compression in some parts of the country, in some provinces. But no, lymphedema's prevalence is actually 1 in 1,000 versus lipedema, 1 in 9. So there's approximately 40,000 patients with lymphedema in Canada, and there's 2.2 million lipedema patients. So then why then do we know so much about lymphedema and so little about lipedema? Well, we look to the gender. This is where some of the bias comes in. So lymphedema affects those assigned male at birth, and women and those assigned female at birth are statistically underrepresented in research. And women's health diseases are often not given the same research, time, attention, or even curiosity that diseases that affect all genders are. Pain in women is also significantly underreported and undertreated. And so we have a painful disease that is also coupled with looking like you might be obese. And so we combine weight stigma with gendered issues, a lot of things. I digress. Let's go back. So lymphedema, all genders, lipedema, almost exclusively those assigned female at birth. What can cause lymphedema? It can be primary, meaning you were born with it, or it can be a secondary as a result of a surgery or injury, or as a result of obesity, sometimes referred to as obesity-induced lymphedema or oil. Lipedema, however, is genetically inherited. No matter what you do, you can't undo your genes. So you were always primed to have the genetics for lipedema. Like a lot of genetic conditions, it becomes when and how is it going to be expressed. We go back to lymphedema. Lymphedema is often asymmetrical. Even if it exists in multiple limbs, it's not often exactly the same fluid volume in each limb. And of course, that can be very difficult to assess, and I know you all have great ways of doing that. But as a general rule, it is asymmetrical. It is unilateral, meaning only existing in one side of the body or one limb, depending on its reason. And it is an accumulation of that fluid in one or more limbs, the lymphatic fluid. Whereas, going back, lipedema, it is triggered at times of hormonal change. So, okay, bam, puberty, pregnancy, menopause, hormonal birth control, and it is always going to be bilateral, both limbs, symmetrical, same on both sides. All right. Lymphedema can affect really any part of the body, head, neck, groin, arms, legs, like nothing is off limits. Whereas lipedema, while there are suppositions that lipedema fat can live in the chin and in the abdomen and even in the breasts, it hasn't been well determined specifically what the incidence of that is. And so for the purposes of our talk, we're going to stick with lipedema as existing in the extremities. In lymphedema, the swelling is going to affect the feet. You are going to see pitting edema. So for those of you who are general interest, pitting edema is where you take your fingers and you press it against the limb and you hold it there pretty firmly. And if it leaves a dent, that would be considered pitting edema. And the depth of the dent would be the degree to what it is pitting edema. But in lipedema, we don't have pitting edema. We might have mild orthostatic edema. So from standing for long periods of time or having dependent legs, there can be a mild swelling, a little bit more of a cuff, a little bit more of a puff. I would say that the only type of really interesting kind of pitting edema we might see is something called a SOC sign. So anytime a patient who has lipedema, below the legs, a type 3, wears any kind of sock, it might leave sort of a deep indent in the leg. And it's from being there for quite some time. And so when you take that off, it might stay for half an hour. Technically, you could consider that some kind of pitting edema, but we really only see that with socks. You're not going to be able to elicit a pitting edema response in a short period of time. And then lastly, lymphedema positive stammer sign, lipedema negative stammer sign. Okay, moving on. I want to be incredibly clear that lipedema is not obesity. That doesn't mean that lipedema and obesity can't co-occur. In fact, they often do. In more than 50% of the cases of advanced lipedema, there is concurrent obesity living with lipedema. They are two separate disease entities that have to be managed separately. And it is very important to identify that lipedema patients may have gotten to a place of obesity for a lot of reasons, and there's issues with anti-inflammatory responses in their body, responses to stress and hormones, and sometimes simply it's so painful to move that can be a real impediment to engaging in significant amounts of physical activity, which might have kept obesity more dormant. So when we look at these two images, we have our lipedema patient on one side and our non-lipidemic patient on the other. Even from the drawings, I want you to be able to assess that in our lipedema patient, we see that small waist We see a disproportionate body, larger arms, larger legs, a cuff at the ankles, sparing of the feet. The BMI, or weight on the scale, of these two individuals might be almost identical, but how the fat is dispositioned on the body really matters. In obesity, on this other side, you're going to see that the fat is pretty even. It goes pretty much everywhere, and it's nice and even. It's not changing the normal anatomy of the limbs until it gets really profound, which can then happen, and of course makes it much harder to sort the two out. So lipedema is not caused by a lack of diet and exercise. It is caused by genetics. It can be exacerbated by obesity. So they're two separate diseases. They can impact each other is what I'm trying to say. We've talked about the fact that lipedema fat is not going to respond to conventional weight loss efforts. So when it comes to lipedema and obesity, I want you to also remember that if you have a complex patient, you're really not sure, go back to pain, because obesity fat is not going to be painful. And that is why pain is a differential diagnostic criteria. Like, that is where we hang our hat, is back at pain. And when we talk about pain, I also want to just include, when a person has lived in pain their whole life, they may not realize that's not normal. And so if you just subjectively ask them, do you have pain? They may not know to answer you correctly. So ask better questions. Ask things like, would going for a 20-minute walk be uncomfortable for you? Is it difficult for you to stand to make dinner? If your cat walks across your lap, does it hurt? Does it hurt when you have your blood pressure taken? Ask questions like that. And then palpate them. Put your hands on the patient with permission and consent, of course. Okay. Now, this is the primary topic of tomorrow's lecture, which is the challenges in Canada. Lipedema, as I mentioned, has been known in the literature since 1940. Yet, it is presently not well supported in Canada at all. One of the big issues is that there is a diagnostic code for lipedema. Now, I'm going to tell you very briefly what that means. When you go to your doctor and they assess you and they say, oh, you have high blood pressure, there's a code for that disease that's in the computer. And your doctor plugs it into your chart, and now high blood pressure lives in your chart. And that information also goes over to the government, and they go, this is the prevalence of high blood pressure. And then they use that information to help inform how much money it's going to go towards research and services, and it helps inform policy. Now, lipedema is acknowledged by the World Health Organization since 2019 as a disease entity, which means they gave us a code. And it's in the newest version of the disease codes. And the problem is that Canada is still using very old versions, 20 years out of date. So even though we do have a diagnostic code, it's not integrated to any province in Canada. And therefore, even if you are officially diagnosed with lipedema, you do not count. You cannot count. And it's affecting things like research and policy. Next, there is a lack of formal education for lipedema in all types of schooling, whether that is medical school, nursing schools, physiotherapy schools, nutrition, psychology, all of it. There is a significant lack. And in that, I mean that with the majority of medical schools and nursing schools across the country, there is no formal inclusion of lipedema in the curriculum or in examinations. And so doctors who have already practiced or already gone through schooling and are now in practice will not have had interaction with lipedema unless they have done that outside of their formal schooling. Same for our physiotherapists, unless they specialize in something like becoming a certified lymphedema therapist, where they might get to talk about it. The only types of specialties of clinicians that sometimes get to talk about lipedema and not very much is vascular medicine. Sometimes they will know a little bit about lipedema. Some of them know more than others. Sometimes plastic surgery, but still the information is not great, and it varies from place to place. And endocrinology. Those tend to be places that they do have a little extra education on lipedema, but it's still not included in their formal, in their curricula or in their examinations. Okay, so that's a big barrier. That's a problem because you're like, well, wait, Emma, you just taught me how to assess lipedema. Who am I going to send them to? Hang on. Okay, next, one of the big problems we have in Canada is that there is no standard of care for lipedema. So a standard of care basically is a series of evidence-based best guidelines that are adopted by the provinces in the country based on recommendations that come from clinicians from the best scholarly evidence that's available on a condition. It's a roadmap that tells you, whichever clinician you see, wherever they are, how to assess you for whatever disease they're looking at. What are the tests they should run? What are the treatments that are considered to be accepted? What is the pathway that you follow? And standards of care are used to make sure that patients receive safe and equitable treatment wherever they are, no matter where you see a clinician in Canada or really anywhere. But lipedema doesn't have a standard of care. And that's because in order to make a standard of care, interested clinicians need to actually want to write one. But if you didn't learn about it in med school, you may not have any actual formal interest in it. And this has become an enormous barrier. So these are the lists of barriers we're going to go through tomorrow in much more detail. There is also no standard coverage in Canada for treatment, whether that be compression garments, physiotherapy, MLD, or surgery. It's sometimes covered on a case-by-case basis, usually after very long legal battles, and it's very frustrating. Patients are really suffering. And lastly, this lipedema is an orphan diagnosis. What does that mean? Lipedema doesn't have like a subspecialty that says we're in charge of lipedema, whether that be vascular medicine or endocrinology. Lipedema can be diagnosed by primary care providers, by nurse practitioners, by endocrinology, by vascular medicine, by obesity medicine, by OBGYNs. Very often the pathway for lipedema starts with physiotherapists, certified lymphedema therapists, and or nurses who assess it and then write letters forward to primary care providers saying, I have assessed this patient. I think they might have lipedema. Here was my assessment. And then from there, that's usually how a diagnosis is done. But if you're thinking, oh, I need to find a lipedema specialist, that doesn't exist. In fact, it doesn't really exist specifically. There's no pathway of the only type of doctor that treats this is blank anywhere in the world. So what do we do for lipedema? I hope you guys are all still hanging in there. Okay, so there's a couple things we can do. Conservative care refers to anything that is not surgical specifically. So in our conservative care management, compression garments is one of the big things that we prescribe for patients with lipedema. And I understand that a lot of the nurses through NSWOC do lots of lower body assessments where you might be working with patients where you're doing things like co-band and trying to decrease the size of limbs. And you need to understand that the reasons for why we wear compression in lipedema, they differ significantly from why we wear basically identical compression for lymphedema. When it comes to lipedema, there is no cure. Not surgery, not anything. Currently, there is no cure. So every one of the treatment modalities we use is about symptom management. When we put compression garments on a patient with lipedema, it can reduce their pain, reduce the fatigue, that feeling of concrete legs and heaviness. It can provide tissue support. And if they happen to be some of the patients who have things like POTS or other types of dysautonomia, it can also keep them more stable throughout the day. Patients who wear compression for lipedema, once they get used to it, will often report that it's like something they just can't go without after that. The feeling of heaviness in the legs really increases without it. So compression recommendations for lipedema, I will always say that you should consult a certified lymphedema therapist who is knowledgeable in lipedema. That would be a referral pathway. If you find a patient who has lipedema, the recommendations for compression related to this, as stipulated under the German guideline and the US guideline, is class 2, flat knit for most. However, it's going to be very dependent on the size of the limb. Some patients will need to start with round knit and ease into flat knit. Flat knit compression can also run $500 to $1,000 per pair, and patients may need multiple pairs per year, speaking to the burden of finances. All right, so next we move over to CDT, or complete decongestive therapy. So our NSWOC team, you guys know exactly what this is. Complete decongestive therapy includes things like bandaging and manual lymphatic drainage. Manual lymphatic drainage is a light massage that can help move stuck lymphatic fluid up through the lymphatic channels, and can also be helpful and used in lipedema. But lipedema isn't specifically edema or swelling, it's pain. So how does MLD help somebody who has pain? By doing MLD, we stimulate the patient into the parasympathetic nervous system. So we relax and calm them. Increasing the lymph drainage can also help decrease pain. That light touch, that effleurage light touch, can help decrease sensation. Lipedema patients might report some or maybe no real change with how they feel with MLD. For some, it lasts for a day and then they don't really feel any different. I was one of those patients, but I will tell you there is a real role for MLD in our post-operative lipedema surgery patients. It's imperative, and it's very, very helpful because you will have actual edema. And so I think the first time I, as a patient, was able to really appreciate what MLD was doing was when I was post-op. So again, certified lymphedema therapists for CDT, another treatment pathway. When we talk about lifestyle, we are talking about a couple things. First, lipedema is inflammatory. Pain is always inflammatory, but lipedema pain is mitigated by inflammation. And so it is recommended that there be anti-inflammatory ways of eating, sometimes called diets. I want to stress that these are not diets with the goal of weight loss. If weight loss happens cursory to that, fine, but it's not the goal. The goal is to reduce inflammatory foods and reduce inflammation in the body. Sometimes this means eating a Mediterranean diet, a ketogenic diet, or what's sometimes called a RAD diet, rare adipose diet. These are things that focus on reducing sugar, reducing carbohydrates, but maintaining that it is not a restrictive caloric diet. They are not sustainable. We want to make sure that the patients are still eating good quality quantities of food and meeting all of their nutritional requirements, but just reducing the inflammatory foods. Stress management. I say that to you in the middle of Lipedema Awareness Month, but stress management for lipedema patients is huge. Bodies under stress produce a lot of inflammation, and that high anxiety type that we have in lipedema patients, that personality type, is very, very, very susceptible to stress. And so doing things like mindfulness, meditation, addressing your mental health, possibly seeing a mental health professional, getting into support groups where you don't feel quite so alone, mitigating the stresses out of your life, and even just realizing that you can't do all the good things for your lipedema in one day, those all help with stress. If you're looking for the primary sort of what the experts in the world will tell you is the best exercise you could possibly do for lipedema, you're going to want to get in the pool. When you stand up in water, even if it's only 4 feet of water, at the bottom of that pool, you are experiencing 80 to 100 millimeters of mercury of compression. Well, our compression garments are somewhere between 20 and 30 or 30 and 40. So graduated compression is what we need. So stand a lipedema patient up in the water and all they need to do is walk. You don't even have to swim. Walk, move your body, enjoy the water. That graduated compression will support the limb. It'll decrease pain on the joints. It can be a little bit challenging if a patient is feeling really stressed about their body image. So finding an exercise class where other people of similar body types are exercising or going to more private pools might help. But aqua, definitely aqua. I did mention that there is surgery for lipedema. Again, none of these treatments are curative, but lipedema surgery can be incredibly effective. So it is called lipedema reduction surgery, and it is a very specialized type of liposuction, completely separate from the cosmetic liposuction that is available in Canada. It is a specialized procedure that needs to be done by someone who is knowledgeable in expertise with lipedema and where there are existing standards of care. Without a standard of care in the country where you are for lipedema, there wouldn't be surgical protocols that are specific to lipedema. And it would also impact patients on the other side of the OR, where they might be dealing with practitioners or nurses who aren't familiar with lipedema and aren't familiar with the complicated comorbidities that go along with it. So for patient safety, and because of a lack of clinicians in Canada offering this treatment in a collaborative care setting with an existing standard of care and policies, lipedema surgery is not available in Canada presently. There are some surgeons who will perform cosmetic liposuction on lipedema patients, but that is not the same thing as lipedema reduction surgery. Surgeries are not a one and done unless you are a super petite human. They are often multi-stage. They take much larger volumes of adipose tissue, of lipedema fat off at one time. In Canada, the max they can take is 5 liters. In places where they do lipedema reduction surgery like Germany, the US, and Spain, it is not uncommon for them to take 10 to 15 liters in a single surgery. Lastly, and I did touch on this already, lipedema surgery must be performed by experts. The literature is very clear on this, including the SK2 German guideline outlines it distinctly, that lipedema surgery should only be practiced and performed by surgeons who are knowledgeable and experienced in it and supported. All right, so we talked about a lot of things. We talked about gender bias in this. We've talked about weight bias, and all of these things, including the fact that sometimes people, clinicians, they just don't know what to do with a lipedema patient once they walk in the door. It can be hard to hear that there is no pathway, no standard of care, no coverage. We have heard from clinicians that sometimes they know that a patient has lipedema, but they didn't bother to diagnose it because what can you do about that anyway? I want to highlight for you how validating, how important, how life-saving it can be for a lipedema patient to be given the information to better understand their body. If it was your body and it changed constantly without your permission, you didn't earn the body you were living in and you couldn't do anything to change it despite every effort you had made, you would have no choice but to think that you had done something wrong. And if you don't know you have lipedema, you don't know that you should be wearing compression, getting in the pool, being kinder to yourself, or supervising if your children have it, if your mother has it, making steps to make sure that your joints are well so that you can maintain your mobility as long as possible. It is so affirming to receive a diagnosis, and to be told that it is not your fault is the most important thing that you can say to a patient if you are diagnosing lipedema. Help remove some of that blame that has stigmatized us because we have stigmatized ourselves. Gender bias is real. Seeing women in healthcare not get their needs met is an unfortunate thing. Seeing women assigned female at birth who live in large bodies be unable to access care is tragic, and it's real. It's well documented. Weight bias is a huge issue, and so lipedema patients are not hopeless. There are ways to improve their quality of life, and doing the things we talked about in our conservative management is step one, and being a good listener and being prepared that lipedema patients may have met a lot of people who didn't understand their illness, and they may be really afraid to have that conversation with you. So if you are the type of clinician who might be approached by a patient who brings a brochure from Lipedema Canada and says, I think I have this, I would love you to start that conversation with, I've heard of lipedema, let's talk about it. So in summary, lipedema is grossly underrecognized. I will spend all of my days and my last dying breath speaking about lipedema and wearing its t-shirts so that people will know its name, because the suffering in silence for this community is not acceptable, and it is something we can fix. And I want to thank you guys all for coming here tonight to fix that with me. I'm so excited that there are a large group of you who are going to go forward into the world having heard what lipedema is, and know that early diagnosis matters. So if we can start screening our prepubescent, our pubescent humans, if we are assessing lipedema in a mother and we know that they've got children assigned female at birth, it is worth having the conversation that it might be genetic, not to scare anyone, but to just sort of bring everyone into the fold. So we have reached the time where I get to stop talking. Blessings to the questions.
Thank you so much, Emma. That was phenomenal. I learned so much about even myself. I'm sitting here going, oh my gosh, yes, that's 100%. The pain on when the doctor just moved my leg once just by grabbing my ankle and moved it over, I was like, oh, and I think they thought I was crazy, but the pain is unbelievable. So thank you so much. We're getting so many positive comments. Everyone is super excited to have all of this information. So we do have some questions, if you don't mind answering for us.
Happy to.
Awesome. So can lipedema fat affect neuroscience? That was one of the first ones we had.
So I want to clarify the question. Are you talking about there being neuropathies? Like you might have numbness, tingling, that kind of thing?
I believe so. Yes, that's what they're talking about.
Yes. Yes. So lipedema, there have been different symptoms described. Sometimes there can be, at more advanced stages, there can be almost like a numbness, areas of the leg that don't seem to be feeling what they're supposed to be feeling, numbness and tingling in the feet sometimes. These can also be comorbid with Ehlers-Danlos, and so it can be quite complex to sort out who is who and what is what. So it's, sorry, the screen changed really dramatically. Are we good? We're still safe?
Yeah, we're
sorry,
good.
Everything's good. I'm just switching to gallery mode for the Q&A. All good.
Don't startle me at this hour. Yes, there can be nerve signs. It's always really important, and I didn't mention this because I meant to, but I didn't. When you suspect a diagnosis of lipedema, it should always be a referral to vascular if you suspect that this patient may also have venous insufficiency or any sort of other comorbid condition that could also not be lipedema. We want to make sure that we really do assess what it isn't, because sometimes that's how we get to what it is. And if they are having issues where they're having numbness or tingling in the feet, then we're also going to want to make sure that their blood work is normal and that we're referring them over to obesity medicine or endocrine, just to make sure that we're not also dealing with an insulin resistant that might be causing an overlap in symptoms. But excellent question. Excellent.
Okay. Good. Thank you for that.
Maybe just before the next question, just if I can catch everyone, just in case, I know some people might have to leave. Just a reminder for everyone in case you came in a little bit later, it is recorded today, so you can go watch this back. So if you have to head out, don't worry, you're going to be able to see this after the fact as well. Same goes for tomorrow. We're going to make some announcements about tomorrow's webinar as well, but it will be recorded both times. So don't worry if you have to head out, but we appreciate everyone who is able to stay on. Thanks so much.
Thanks, Troy. So yeah, one of the next questions. Do bruises have to be present for a diagnosis of lipedema?
I mean, it is in the diagnostic criteria. It is. So I don't feel comfortable giving you the it has to, but the easy bruising, tissue fragility, yeah.
Yeah.
I would have to ask though if every other symptom is present, but that patient is just covered in bruises. Well, maybe they just have a history of weird bruises. They don't have to be physically covered in bruises in front of you at that time. Okay. So add that to your patient questionnaire. Even just asking a patient, do you bruise easily? Would be enough, but it's not always common that you're going to see a patient who's fully covered in bruises unless they do. I have a lipedema friend who does Muay Thai. I don't know how she does Muay Thai, but they kick each other. Anyway, I digress. Yeah. Not always, but maybe yes.
Okay. Okay. Is there a correlation between fibromyalgia and lipedema? Both conditions are challenging to diagnose due to potential lack of education, and both involve pain in specific areas. They are commonly affecting overweight females.
Yes.
Okay.
Yes. There is a statistical documented series of research on the overlap between fibromyalgia and lipedema. It's also suspected that a lot of fibro patients might actually be lipedema patients who have just been diagnosed with fibro. And so, yes. So if you're looking for good research on that, please head over to your scholarly sources. I believe Dr. Karen Herbst does have some excellent articles on fibromyalgia and lipedema. So yes, yes.
Good to know. I've been diagnosed with both, so I'm like, okay. I always thought when they first said fibromyalgia that maybe it was lipedema and they didn't recognize the lipedema because I have other signs. So yeah, it's, or I have both, who knows. Can birth control pills trigger lipedema? I know you mentioned the hormonal factor. I wouldn't say trigger though. Is that the right word to say? Or yeah, it is? Okay.
It is. Okay, so I will answer this with the caveat of we still need research to definitively say what is 100% setting lipedema off and what is not. Is like any syndromic disease, it's multifactorial. What we can tell you is empirically, from people with lived experience, there are significant numbers of reports of patients stating that they started a hormonal birth control and then had a rapid progression of symptoms, whether that be the insertion of a hormonal IUD and then significant weight gain, 50, 60, 70, 100 pounds, and then almost immediate immobility. We have other patients who have been on birth control for a very, very long time, and their disease progression has stayed relatively stable. Lipedema is interesting in that way, is that yes, it is progressive, but it doesn't always progress at the same rate for every person. And that's why those triggers we talked about are so multifactorial. So what I would say as a women's health nurse is when you go into whoever prescribes your birth control and you suspect you have lipedema, bring literature about lipedema and ask good questions about that. It's likely a Canadian OBGYN may not know about lipedema, but if you bring forward, hey, I think I have a hormonally triggered disease, what are my options for lower hormone birth control options, such as things like copper IUDs, which don't have any hormones? Again, there are options. Those are people you can talk to. But yes, it is empirically documented that birth control can affect lipedema symptoms and progression.
Okay, good to know. Can we use compression wraps or tubular compression to treat lipedema? The other one that came in that's sort of similar, intermediate pneumatic compression. Is it beneficial?
Yeah, okay, so let's talk about, we're talking about short stretch bandages and Faro wraps, that kind of thing right now?
Yes, yes.
Okay, so there is, I'm not a certified lymphedema therapist, so I can only tell you what the certified lymphedema therapists in my life have told me and what the research says. There can be a role for that sort of complete decongestive therapy within lipedema. Sometimes that role is if you have a patient whose limbs are edematous and large, if there's a period of time where you're doing some CDT to sort of bandage and make the limbs smaller, sometimes that's used before they get measured for compression, so that they don't go into a pair of compression and then immediately decongest, and then the $800 to $1,000 pair of compression is huge and they have to just do it again. So kind of that same strategy that you might use with a lymphedema patient. It can be really painful to bandage lipedema patients. Like the tension that's sometimes required and that extra feeling, it can be a lot. Some patients tolerate it well, some patients don't. Coban is a no. Don't bother with that with lipedema patients. It can get deeply into folds and cause a lot of pressure points. Think about those pain places we talked about, right at the medial knee. Like if you are Coban wrapping someone there and it's getting in, too painful. On to the pneumatic compression. Yes, it can be very helpful. Very helpful. Pneumatic sequential compression devices used either in clinic or at home can provide a lot of relief. They should be used slow and low because, again, we're very sensitive to pain and pressure. So I learned the hard way in getting in one of those pumps that you shouldn't just crank it to 12. So slow and low. And of course, everyone who's doing any type of compression therapy, whether it is CDT, compression garments, etc., should always be assessed by a certified lymphedema therapist, have their vasculature checked and make sure that it is safe and appropriate for that patient to be in compression.
Okay. Yes, I agree. High compression is painful. So I always say start low and slow. That's kind of where I'm at right now. On bad days, this is a personal question. On bad days, not from me, but from one of our members. On bad days, my lower legs burn. Can lipedema cause that?
Yes. Sometimes the pain is described as burning. Sometimes it feels like creepy crawlies under the skin. Sometimes it feels like cold water rushing. Thermoregulation in lipedema is also an interesting empirically noted sign. So when we touch their skin, it's often cold. They'll often report that they have the iciest bums, thighs, feet, anything where it's affected. You'd be totally warm in the core, but arms are like ice. There's other symptoms too. Things like mottling in the skin that looks like libido. It's called libido reticularis. Looks like splotchy We can get into that, and maybe we'll do a part 2 on the like really extra symptoms. But as far as what does pain feel like, it's usually worse towards the end of the day, after periods of dependent legs, standing, or stress, or if you've been out of your compression. And yeah, it can feel like burning, tingling. It can feel nerve-like. Yes, that has been reported.
I think you answered this, but I will ask again. What happens with lipedema in pregnancy? So again, a hormonal thing.
So sometimes nothing. Sometimes a patient will become pregnant and there may be a significant amount of weight gain in pregnancy. And then secondary to that, they find that they're having lots and lots of symptoms. When you're a pregnant person, it can be really hard to sort out what is a normal feeling. Like you're growing a whole human being in a 9-month span, your body's changing rapidly. So the answer is that not every patient who becomes pregnant is going to have a rapid symptom progression, but some will. Sometimes it's at the cessation of breastfeeding. So maybe you have a big hormone surge from getting pregnant. You maintain those hormones while you were breastfeeding, and then as soon as you're not, and now all of a sudden it hurts when you stand, you can't run around with your kids, your body is changing, and you just think, oh, this is what a postpartum body looks like. This is just my new postpartum body. It may not just be that. Other patients, it doesn't change at all during pregnancy, and then they get to menopause, and then the change happens. For some of us, it already changed in puberty. It gets worse in pregnancy. The answer is really subjective. It's subjective.
Okay. Someone's asking, is a vascular referral the best way to get a diagnosis in Canada?
In Canada, it's okay. Lovingly, it's the Wild West. So here's some things you can do if you are like, where do I go? Start with going to Lipedema Canada's website, lipedemacanada.org. And on there, we have a list of clinicians in every province who have self-identified that they know enough about lipedema to sort of help out. Okay, so we start there. A lot of vascular surgeons have 3, 4, 5-year waiting lists. That's a really long time to wait to find out if you have a disease. The best pathway that we have found is obviously start a conversation with your primary care provider. Have that conversation. Go in with a brochure and some information. When doctors don't know what it is you're talking about and you come in without anything, they might just not know how to receive you. But coming in with some information can actually be really alleviating for the clinician as well. And the best place that we know of is find a certified lymphedema therapist who is knowledgeable in lipedema. We have a bunch of them listed on our website. These will be people who are trained in different techniques, Vater, close, etc. And if you do that, very often they can perform the assessment and really do a really great head to toe. They know what they're looking at. From there, a lot of them are excellent at doing this. They will write letters that you can then take to your primary care provider. It sort of helps bolster that's not the first time you're having that lipedema conversation. Once you've done that with a CLT, they can't provide a formal diagnosis, but they can provide their written assessment. Only a doctor or a nurse practitioner can provide you a formal diagnosis, which is helpful because once you have a formal diagnosis, you can apply both for the disability tax credit and also have apply your expenses, your medical expenses towards the CRA for cash. I'm not saying this right. Our president, who is also very knowledgeable, and this is probably in the comments going, she's saying it wrong, in order to have some of your medical expenses covered back on your taxes.
On your taxes, yeah, you can claim them up to so much, I believe.
Yes.
Yeah. Troy, I think you are going to say something.
I was just going to mention again, just before, I know we have got so many people who are staying on, which is fantastic to see. And I know we still are getting questions here, which is great. I just want to remind everyone to, we just put the Lipedema Canada link in the chat there if you want to visit it right away. We are going to be doing it. There's a survey that's going to pop up in your browser once you do leave at any point today too. Please take a second to fill that out as well. It also evaluates a little bit of how much you knew about lipedema beforehand, how much you've learned now, where your comfort level is ahead of tomorrow's webinar. But that was just want to do a quick little reminder. I'm gonna have to hop off here, Bev and Emma, and I just wanted to personally say thank you on behalf of NSWOC too. I know Bev has done the same as well, but it's been so important to have you on, and we cannot wait for the part 2 of this webinar. Again, we'll do a little announcement to everyone after the fact. But I just want to say thank you from the bottom of our hearts, because it's been so eye-opening, and I'm just going to echo everything we see in the chat there. So thank you so much, Emma.
Yeah, no, thank you guys so much.
Yeah, and I think what we'll do, because I don't want to hold Emma too late tonight, there's questions still coming in. Maybe what we'll do is just gather those questions, and if Emma has time, she can answer them. Is that okay, Troy and Emma? It's up to you guys.
Yeah, why don't we take that, because we'll have it tomorrow anyways there. So we'll I'll group all these. We have a report here from that, so no problem. We can do that. We can definitely do that.
Yeah, it's getting late.
I don't know what time it is where you are, but it's all good. So I look forward to seeing everyone for the part 2 of this. That'll be really good, and I'm looking forward to reading all your questions. Thank you guys so much, Bev and Troy and NSWOC, for making a platform for us to talk about this very poorly understood disease. I'm deeply grateful on behalf of myself and the rest of the lipedema community for that. So very much looking forward to it. And remember that the Lipedema Canada is run completely and solely by volunteers. And if you think the work we're doing is important, please consider supporting the organization so that we can continue to educate folks like you. So thank you.
Thank you so much, Emma.
Everyone.
We'll see you all tomorrow.
Have a great night.
See you tomorrow.
Bye-bye.